Good afternoon. I'm going to talk about the ENT emergencies. We have only few emergencies. I will start with the epistaxis, one of the common reason for ENT admission. Nasal bleeding, most of the time it is self-limited condition, but rarely it can be life-threatening. Epistaxis can kill even an adult. Therefore, we should not treat the epistaxis as a harmless event. About the causes of the epistaxis can be divided into local systemic causes or it may be idiopathic. Local causes including nasal trauma, nasal surgery, intubation, allergic rhinitis, chemical irritants, some topical nasal drops, steroid drops can cause the bleeding, and some nasal deviation, septal problems, septal deviation can present with epistaxis, and some benign polyp like inverted papilloma can cause bleeding, and obviously malignant neoplasm of the nose and sinuses can present with epistaxis, and nasopharyngeal angiofibroma is an important case in the adolescent male. It is a benign tumor arising in the nasopharynx. It has androgen receptor, therefore the young boys who are adolescent male who present with epistaxis should be excluded for investigated for the nasopharyngeal, should exclude nasopharyngeal angiofibroma. Systemic causes including the hypertension, some vascular malformation like familial hemorrhagic telangiectasia or some rarely vasculitis condition can cause bleeding. And patients on anticoagulant, liver failure, coagulopathy, platelet dysfunction, those are systemic causes. It is important to know about the nasal blood supply. So nasal cavity is supplied by both internal and external carotid arteries. Therefore, it has rich blood supply and many arterial and venous anastomosis are there. There are two important anastomosis. One in the little's area called Kisselbach plexus, located in the anterior part of the nasal septum called little's area. Another plexus is in the posterior part of the septum. It is called Woodruff area. These are the plexus bleeding arise from. It is same thing. It is important to take a good history including these measures, these points. So we should ask, when we get a patient with epistaxis, we should complete the history with other nasal symptoms like nasal obstruction, rhinorrhea, anosmia, facial pain, headache, which indicate the nasal pathology. And we should ask for the nasal trauma, history of nasal trauma, surgery, previous episode of the bleeding, and about the severity of the bleeding, and we should exclude we should ask for the other systemic causes of the epistaxis. And the physical examination include the general examination including the other bleeding manifestations. And we should examine the cardiovascular system for blood pressure, pulse rate, and other vital signs. Then we go for the rhinoscopy. These are the usual investigation we do for the adult patient who present with epistaxis. We do full blood count, liver ESR, liver function, and X-ray, sinuses, OMA view, then RNA, and if indicated, CT scan, not for all. And the management of the epistaxis start with the first aid. So we should start the first aid even before the history taking. So this is the best position to keep a patient with epistaxis. Sitting upright, it will reduce the venous congestion of the nasal cavity, and incline slightly forward and mouth opening. This position will spit out any blood from the mouth, and while on breathing from the mouth, while breathing on my mouth, they can use the finger pressure to reduce the bleeding. They can apply finger pressure to the cartilaginous part of the nose. It means over the little's area. We should apply constant pressure for 5 to 10 minutes. Most of the time it will stop the bleeding. With that same position, this position with the finger pressure applying to the little's area, same time we can apply some ice pack over the upper part of the nose and the forehead area. Epistaxis ladder, this is how we practice, how we manage the epistaxis. We start with the first aid including position, finger pressure, and the ice pack. Next step is the silver nitrate cauterization. If fail, we can go for anterior nasal packing. Next step is the anterior and posterior nasal packing. If all are failed, we have to go for the arterial ligation. Same thing we discuss with the ENT UK guideline. After the first aid, we do the nasal cavity examination, also rhinoscopy. For that, we have to clear the blood. We can suck out or we can remove the remaining blood from the forceps, and then we should decongest the nasal cavity. We can use either silomethicillin nasal drop. Commonly we use silomethicillin nasal drops for the decongestion. Otherwise we can take some cotton wool soap soaked with adrenaline, and we can insert to the nasal cavity. Those will decongest the nose and it will reduce the bleeding, as well as it will give the space for the proper examination. So the next step is that we do the anterior rhinoscopy. It means we are examining the anterior part of the nose for the any bleeding point. If we can see a bleeding point, we can cauterize the bleeding point with silver nitrate or with the bipolar diathermy. Next, the middle, it's not clear. The first part saying that, and if we can see a bleeding point, we can cauterize with the silver nitrate or the bipolar diathermy. Middle pathway mentioning that there is a low volume continuous bleeding, but we can't see a bleeding point. So we can't see bleeding point, but there is a low volume bleeding. In that case, we have to apply a dissolvable nasal pack, and we can try with after the first aid, we can use the dissolvable nasal pack, and we can try IV tranexamic acid for the stop bleeding. These are the available. These packs are available, soft packs. It is very easy to insert after lubricating with some antibiotic cream or at least lignocaine gel. We can just insert. Low volume bleeding can be stopped with these packs. The third part is saying that we can't see a bleeding point, but there's a profuse bleeding. That is the dangerous thing. Those patients need hospital admission and they may need resuscitation, including IV cannula, IV fluid, blood group in NDT, and IV tranexamic acid, and they need some better packing, some pack which apply much pressure. This is the traditional anterior packs we are using here. It is same to the throat pack. We should pack the nasal cavity by layer by layer. First step, we apply the pack for the floor of the mouth, floor of the nasal floor, along the nasal floor. Second layer over that layer, like that we apply we pack the nose layer by layer, giving the maximum pressure to the bleeding points. It is called we are packing the anterior nasal cavity, so it is called anterior nasal pack. Sometimes it will work. If not, we can try for the posterior nasal pack and the anterior nasal packs. In the posterior nasal packs not available, so we use the Foley catheter. We can take Foley catheter, can insert to one nostril up to the throat. When we see the balloon tip of the Foley catheter in the throat, we can inflate the cup with 10 cc or 15 cc of distilled water. Then we pull out the Foley catheter until it lodges the nasopharynx. So it blocks the posterior part of the nasal cavity, including the Woodruff plexus. So we anchor with the cord clamp. Then we need further anterior nasal packing. Those anterior nasal packing and posterior nasal packing will distort lot of bleeding most of the time. If it is not improving, that pink color chart showing, we need some advanced options like sphenoparietal artery ligation, anterior ethmoidal artery ligation, or at the last option we can do the external carotid artery ligation. Or interventional radiologists can do the angiogram and embolize the bleeding vessels. When we use the nasal packs, we remove it within after 24 to 48 hours, and we'll discharge with the silomethicillin nasal drop and some antibiotic cream for the bleeding areas, cauterized areas. There are some special cases, like sometimes patient who are on anticoagulant present with epistaxis. In that case, we have to stop or titrate the drug. If they present with profuse bleeding, we can reverse the effect of anticoagulant with the protamine sulfate or vitamin K. Another special case is unconscious head injury patient. Usually they present with profuse bleeding, so we have to do the nasal packing. But there's a risk if they have a skull-based fracture, our nasal packing can dislodge the fractured bone segment and can worsen the brain damage. Now moving to the next emergency, it is septal hematoma. Septal hematoma is a rare condition arise due to the nasal trauma. Usually they present with the nasal obstruction 2-3 days following the nasal trauma, most of the time without bleeding. That is the problem. If the patient develops a bleed, epistaxis nasal bleeding following trauma, they usually seek medical treatment. But in this case, they don't develop the epistaxis most of the time. Therefore, they present late. We can see in the septal hematoma, both pictures say that this hematoma developed in the both sides of the septum, in between the septal cartilage and the periosteum. So usually cartilage is devoid of the blood supply. It is fed by the blood vessels in the perichondrium. So in this hematoma is spread between the septal cartilage and the perichondrium. Therefore, perichondrium is pushed away from the septal cartilage, then this compromises the blood supply to the septal cartilage, causing the cartilage necrosis and several complications. Therefore, they need early surgical evacuation, incision and drainage. We do under sterile condition, and after the draining the hematoma, need the anterior nasal packing for prevent the recollection, and we use antibiotic also. And these are for prevent. We should treat the septal hematoma early for prevent these complications. First photo is showing the septal perforation because of the compromised blood supply, septal cartilage necros, and they end up with the septal perforation. Second photo is showing the saddle deformity, again because of the septal cartilage necrosis, that they develop some saddle deformity in the nose. Now moving to the next emergency, some complication of acute sinusitis. Acute sinusitis is a common problem, but especially the immune compromised people can develop complications of acute rhinosinusitis. The infection can spread to the bone, causing osteomyelitis. Famous one is spots puffy tumor in the forehead bone. So the infection can spread to the brain, causing meningitis, various intracranial abscess and cavernous sinus thrombosis. Those are rare, but commonly the infection in the sinuses can spread to the orbit, causing orbital complication of the cellulitis. The complication can be divided into 5 classes according to the Chandler's classification, class 1 to 5 orbital complication. This is easy to understand. First photo is showing that green color area, green dots are the infection. So first Chandler's classification, class 1 orbital complication mean preseptal cellulitis. It means the infection anterior to the orbital septum. So it is just like conjunctivitis or eyelid inflammation. So the second complication is the orbital cellulitis. Second photo showing that green color dots expand in infection, expand into the orbital contents. Class 3 complication is subperiosteal abscess, the abscess of pus collection in between the lamina papyracea and the orbital periosteum. It means some outside the orbital periosteum. So the fourth complication is orbital abscess. It means the abscess formation in between the extraocular muscles, orbital nerve and blood vessels. The fifth class 5 means cavernous sinus thrombosis. So these complications include in subperiosteal abscess, orbital abscess and cavernous sinus thrombosis can blind the patient. Therefore, it is important to treat the early. So orbital cellulitis patient present with fever, malaise, and they usually have a recent history of sinusitis or upper respiratory tract infection. And proctosis, they present with proctosis and ophthalmologia as the cardinal sign. They develop orbital pain, pain on the eye movement, chemosis, eyelid swelling. With the progression of the disease, they will develop the decreased color vision, then visual acuity and the apparent pupillary defects. So the commonest pathogen of the sinusitis are Streptococcus pneumonia and other streptococci, Staph aureus, Haemophilus, and some anaerobes. Therefore, the administration of the appropriate antibiotics are the main step of treatment. So then corticosteroids are controversial. Some advised to start, but most of them advised to start corticosteroid after 2-3 days after the IV antibiotic when the infection is settled. And we can treat the sinusitis with nasal Duocin, nasal steroid, and antihistamine dose for the sinusitis part. But if they are not improving within 24 to 48 hours of IV antibiotic, or if the vision is deteriorating, they need CT scan and surgical intervention, orbital decompression or lateral catheterectomy for drain the abscess. Now, another similar condition, acute invasive fungal sinusitis. It is the fungus, usually fungus enters to the nose and paranasal sinuses and can grow there without making much problems. But again, especially with the patient with immunocompromised, various immunocompromised condition, the infection can, those fungi can invade the neurovascular bundle, bones, and the orbit, causing acute invasive fungal sinusitis. Rhinosinusitis. It is important because of its aggressive course and high mortality rate, even up to 80% mortality rates. There are two common fungus identified. One is from the Aspergillus species and another from the Zygomycetes order. The mucormycosis is the common fungi we see. The presentation of acute invasive fungal sinusitis are non-specific. Sometimes they present with the features of sinusitis like rhinorrhea, nasal congestion, facial pain, pressure, or fever. But sometimes, even with the advanced cases of acute invasive fungal sinusitis, they don't have symptoms of the acute sinusitis. With the worsening of the disease, they can develop facial pain, erythema, eye complication like proptosis, diplopia, visual loss, headache, and they can develop multiple cranial nerve palsies and the CNS defects. So they need the basic blood investigation for the immune compromised state, and they need CT scan and MRI scan and tissue biopsy for the confirmation of the diagnosis. Management is a management need multidisciplinary approach. It is the key step to successful management. And there are 3 steps of treatment: reversal of the predisposing state. It means that we should correct the neutropenia, ketoacidosis, and diabetes conditions, and they need surgical debridement and the antifungal therapy. Now moving to the next one, foreign body in the nose. Foreign body in the nose is a common presentation, but not the emergency. But button batteries become an emergency. Button batteries, batteries which available in the toys. Children put button batteries available in the to the nose, throat, or ear most of the time. Those button batteries contain alkaline materials. When they touch with the acidic body tissue, it starts to leak the alkaline content, causing the severe damage to the our living tissue, mucosa, especially mucosa. So button batteries in the nasal cavity, ear, throat, esophagus, trachea are always emergency. We have to remove it as soon as possible. This photo is showing the corrosive button battery in the center with severe necrosis of the septum and the inferior turbinate, which is in the nasal cavity. So it is an emergency. Now moving to the airway emergencies. Upper airway obstruction, patients present with the stridor. The stridor, definition of the stridor is an abnormal high-pitched sound produced by turbulent airflow through a partially obstructed airway at the level of the supraglottis, glottis, subglottis, and or trachea. Therefore, it is stridor is a symptom, not a diagnosis, and we should identify the cause of the epistaxis and treat. When the obstruction is at the supraglottis or glottis, at the level of the vocal cord or just above supraglottis, they produce inspiratory stridor. If the obstruction is at the intrathoracic trachea or airway, they cause expiratory stridor. And if the obstruction at the level of subglottis or cervical trachea, they can present with the biphasic stridor, both during the inspiration and the expiration. So identification of the stridor sound is important. Therefore, I just put some video to show the stridor sound. This is a patient awaiting for the tracheostomy. So, that is that she has inspiratory stridor with severe recessions. It is due to bilateral vocal cord palsy. So the children can present with acute stridor due to a foreign body aspiration or various infection like viral croup, bacterial tracheitis, retropharyngeal abscess, peritonsillar abscess, or acute epiglottitis, or as due to the anaphylaxis. And children may present with chronic stridor mainly due to the congenital malformation like laryngomalacia, bilateral vocal cord palsy, subglottic stenosis, laryngeal waves, papilloma, and some rare causes also. And the adults can present with acute stridor due to airway trauma, neck trauma, following penetrating neck trauma, and anaphylaxis, and some acute infection like acute laryngitis, epiglottitis, retropharyngeal abscess, inhalation injury, and aspiration of foreign bodies. And the adults can present with chronic stridor mainly due to the laryngeal tumors, benign polyp or respiratory papillomatosis or laryngeal carcinoma, and some chronic laryngeal inflammation due to TB or sarcoidosis, bilateral vocal cord palsy or tracheal compression due to goiter or mediastinal tumor, and again may be due to iatrogenic due to the neck surgery or prolonged ventilation. This is just showing the severity of the acute epiglottitis. Epiglottitis can present with older children or adult, but the incidence is reduced due to the hip vaccination. Now this is showing the severity of the inflammation of the epiglottis in the acute epiglottitis. There's a very limited space for the breathing. Acute epiglottitis usually started with the sore throat and rapidly progressed to the total dysphagia and the stridor. If we suspect a patient with acute epiglottitis, there are a lot of don'ts. Do not disturb the child. No X-rays, no throat lamination, no IV cannula. We should confirm the diagnosis in an safe environment, ideally in the operation theatre in the presence of anesthetists, ENT, pediatricians. So we can manage the acute epiglottitis with IV antibiotic in ICO, HDO setup, probably mainly with the third generation cephalosporin. Rarely they need elective intubation or tracheostomy. This is another condition, another infection showing the severe retropharyngeal abscess. It is common in between children under 4 years of age due to the retropharyngeal space lymphadenitis. It has the abscess formation in posterior to the pharynx and anterior to the vertebral muscles. They should be present with fever, throat pain, and dysphagia. But with the advanced cases, they can develop the airway obstruction. This is showing another cause for the stridor is common cause is foreign body in the foreign airways. It is showing some metal foreign body, and the foreign bodies obstructed in the larynx, or large foreign bodies in the trachea, or sharp foreign bodies, and the button batteries become acute emergencies. We should remove it suddenly, immediately. This is some nice video clip showing the foreign body in the airway. This video is belong to the Asavajnasa in LRH1 LRH case. This is the bronchoscopy of the same patient. That whistling part of a toy has gone to the right main bronchus. Now moving to the upper airway obstruction management, we should assess the airway adequacy. So the clinical assessment with the respiratory rate, stridor, subcostal, intercostal resistance, pulse rate, and the cyanosis are the best way of assessment, clinical assessment, and we should combine with the pulse oximeter, saturation, and the arterial blood gases. So the management of the acute airway obstruction. First one is call for the help. You need help. You can call to the anesthetist, ENT, physicians, and pediatrician. So the management start with the, we should support the airway with ABC, airway breathing circulation approach. They need high flow oxygen. And the Heliox is a good combination but not available. Heliox means that 80% helium and 20% oxygen. Helium is low density air which has density is lower than the nitrogen. Therefore, it can easily pass through a narrow airway. So helium is available. It is a good option. And the next point is adrenaline nebulization. For the adult patient, we can take 2.5 or 3 ml of undiluted 1 in 1000 adrenaline for the nebulization, and they need IV steroid. And the position of the patient, which is it is the comfortable position for the patient. We can prop up the bed, or sometimes they prefer the sitting position. Like that, whatever the position patient is comfortable. Those are the primary measures. So if sometimes they need some airway intervention for manage the airway obstructions, like cricothyroidotomy, endotracheal intubation, or tracheostomy. This is showing one photo showing the site for the cricothyroidotomy. Rarely we need this procedure. We can palpate the thyroid notch easily and the cricoid cartilage. In between the thyroid cartilage and cricoid cartilage, there's a soft tissue. There's a that I don't have a in between, so there's a soft tissue region in between the thyroid cartilage and the cricoid cartilage. So we can palpate thyroid notch, cricoid cartilage. Then in between two cartilage, we can insert wide bore cannula as the cricothyroidotomy. It will save the life. And or endotracheal intubation, or most of the time they need tracheostomy. Tracheostomy may be emergency or elective depending on the severity of the stridor. We can do under general anesthesia or local anesthesia. We do preferably on the operation theater, or even can be done at the bedside. Usually need neck extension for the tracheostomy, but there are some cases for the patient with acute stridor, severe upper airway obstruction. The neck extension was the stridor. So in that case, we have to do one without extending the neck. And we make horizontal incision midway between the cricoid cartilage and the supraesternal notch. In the real emergency, we can use the vertical incision also. We dissect at the midline, and thyroid isthmus can be divided, and we can use a vertical incision, or we can remove part of the thyroid tracheal cartilage at the level of second, third, or fourth tracheal rings. Now moving to the ear emergencies. This is a patient with acute mastoiditis. So patient can develop acute mastoiditis as a result, as a complication of acute otitis media or chronic otitis media. Acute or chronic otitis media is a common complication. The infection can spread from middle ear to the mastoid hair cells, causing acute mastoiditis. Usually they present with fever, ear discharge, ear pain, and neutrophil leukocytosis and high CRP count. They need basic blood investigation and years of full culture and EBST. So we usually start with IV coamstre, they need aggressive treatment with IV antibiotic because if left untreated, they can end up with the brain abscess, meningitis, or sigmoid sinus thrombosis. If not responding to the IV antibiotic, they need CT scan and sometimes mastoidectomy. Another emergency is perichondritis. Perichondritis means infection and inflammation of the perichondrium, ear cartilage. So they need usually it is due to following the ear trauma. Usually they need a systemic antibiotic. Usual pathogen is Staphylococcus aureus, so we can use cloxilin, coamsclave or ciprofloxacin. For they need systemic antibiotic and analgesia. Again, if left untreated, they can go into the cauliflower ear. Another emergency, it is a perichondrial hematoma. It is due to following the trauma. It is similar to the septal hematoma. The hematoma blood clot occur in between the ear cartilage and the perichondrium. Separating the perichondrium from the cartilage, which means that it compromises the blood supply and necrose the cartilage. So they need early aspiration or incision and drainage of the hematoma for prevent the cauliflower ear. This is the cauliflower ear. It is due to the following perichondritis or perichondrial hematoma left untreated. Now another complication is another problem is a sudden deafness. Sometimes healthy people are present with deafness, hearing loss immediately, suddenly, within few hours, few days. So it is emergency. So when we do the when we examine the patient, they usually have sensorineural hearing loss. It means the pathology in the cochlea or vestibulocochlear nerve. The common causes are vascular. It may be due to vascular causes. The patient with vasculitis, some condition with vasculitis, or diabetes mellitus, hyperlipidemia, they can develop some microvascular complication in the cochlear blood vessels, causing reduced blood supply to the cochlea and causing the sudden onset sensorineural hearing loss. And there are some viruses like measles, mumps, rubella, and even COVID-19 can cause the vestibulocochlear and vestibulocochlear nerve damage, causing the sudden deafness. And some autoimmune conditions can present with sudden deafness, and rarely cerebellopontine angle tumors can cause the sudden deafness. So the history examination and neurological examination is needed to identify the pathology. So these are the investigation we do routinely. Full blood count, ESR, fasting blood sugar, lipid profile, TSH, VDRL, because those hypothyroidism, syphilis even can do the vasculitis and same problem. So they need serial pure tone audiogram to see the improvement, and rarely they need, if not improving, they need MRI scan to extrude the acoustic neuroma or vestibular CP angle tumors. Moving to the management of sudden onset sensorineural deafness, they need bed rest, and the steroid are the main step of the treatment. We can use oral prednisolone or better intratympanic dexamethasone injections are better than prednisolone because the dexamethasone reaches the cochlea quickly, easily. And acyclovir is controversial. If you suspect some viral pathology, acyclovir can be used. Most of the time with the intratympanic dexamethasone or oral prednisolone, methylprednisolone, their hearing will improve with time. If not improving, they need hearing aid. Okay, thank you. That's all.
Uh, Thank you very much, Roshan, for that very simple and important lecture. That my question is actually that one of the common problem in the medical world, medical problem is the distance. That most of the patients are being labeled as hypertension emergency. But when it is a distance settled, sometimes when they settle down, by the time the patient is discharged, they never been the some people are not the diagnosed patient of hypertension. And when they discharge, that is stopped and treated, then the blood pressure goes down to normal. Actually, the problem is that whether the hypertension cause of distance, so that distance is the reason for the hypertension.
Yes.
That's the bit of a problem.
I think both is possible. Some hypertension is one of the systemic cause for the epistaxis because if you have high blood pressure is rising and rising, so tiny blood vessels can rupture and can present with the epistaxis. I think it is better to rupture a nasal blood vessel and present with epistaxis before developing some intracranial hemorrhage. So sometimes with the high blood pressure, people with high blood pressure can rupture tiny blood vessels in the nasal cavity and can present with the epistaxis. But sometimes when the patient develops the epistaxis due to the anxiety and sympathetic activation, their BP is high. So I think most of the patient when we examine, their BP is high, but with time they will become to normal. In that case, we can't diagnose as the epistaxis due to the hypertension. So we need further investigation like RNE. Usually we do the RNE for all the patients or the adults with epistaxis. So we try to identify another cause rather than saying the hypertension in most, I think almost all the cases. But sometimes we can't identify another cause. So in that case, it may be idiopathic. Even idiopathic epistaxis, due to the anxiety, they develop hypertension, increased blood pressure, but they become normal. So they develop both way, and the hypertension can cause the bleeding, and again, the epistaxis due to anxiety, people can develop high blood pressure on that time only.